Good afternoon, everyone, and welcome. Thank you very much for joining us here today. My name is Christopher Smith with the Alberta Bone and Joint Health Institute, and it's my pleasure to host today's session on balanced scorecards on behalf of the Bone and Joint Health Strategic Clinical Network. Just a couple housekeeping items. We are recording this session, so for all people who couldn't join us in person today, or if you want to refer back to this session, we will be sending out a package, and we'll include the slide deck as well as the link to the video so that you can refer back to it as your schedule permits. I want to welcome everyone today. We do have attendees from all across the different strategic clinical networks. So we don't have just bone and joint health people. We have people from all different walks of life. So welcome and thank you very much for joining us. For those of you who don't know or perhaps are not aware of the relationship between the Alberta Bone and Joint Health Institute and the Bone and Joint Health Strategic Clinical Network, we are a independent nonprofit organization. Our mandate is really to serve as a catalyst for improving bone and joint health. And this means that we partner and collaborate very, very closely with the Bone and Joint Health Strategic Clinical Network on several quality improvement initiatives in bone and joint health. We've been using the balanced scorecard methodology for about 6 years, the better part of 6 years now. And it's a tool that's proven very effective in helping teams track their quality improvement efforts and to identify opportunities for improvement. And it's my pleasure to share this knowledge with all of you and see this methodology spread further. Balanced scorecards themselves are not new. They've been around since the 1970s. They're first developed by two consultants out of the Boston Consulting Group and brought initially to the private sector because Kaplan and Norton, who developed it, recognized that companies that just looked at their profitability were missing out on part of the picture. And they recognized that if you wanted to be successful in the long term, you had to look at multiple things. Success was not just one thing, it was actually lots of little things. And the framework that Kaplan and Norton first developed looked at 4 specific dimensions: learning and growth, your internal processes, customer service, and the financial aspect. And what they posited was that if you looked at all of these things and you were actually able to measure success in all of these areas, then you would increase your probability of long-term success. Since that framework was first put forward, 40 years ago, the balanced scorecard methodology has really expanded beyond the private sector, and it's used quite extensively in the public sector and government sector, as well as in the nonprofit area. And the reason for that, I think, is quite obvious, that in areas, for instance, in healthcare, success is not one thing. We don't even measure success in quality of healthcare as one thing. We measure it as many things. In Alberta, we have the Alberta Quality Matrix for Health, put forward by the Health Quality Council of Alberta as our definition of quality in healthcare, and that has 6 dimensions to it: access, acceptability, appropriateness, effectiveness, efficiency, and safety. So if you're defining success in these very complex environments as being a multi-dimensional thing, having a tool that lets you actually look at multiple dimensions simultaneously is a very attractive type of tool to put into place. And that's why balanced scorecards have proven very effective in healthcare. Lots of companies out there and lots of organizations use balanced scorecards across pretty much every gamut: universities, private sector, for-profit, nonprofit, as well as healthcare agencies. So it's a very versatile, powerful tool. One of the aspects of the balanced scorecards that I really like is the fact that it explicitly recognizes that we have limited resources. And in fact, in our entire environment, we have limited limited hours in a day, we have limited staff, we have limited beds, we have limited operating room time. We have these constraints that exist in our environments. So searching for perfection is virtually impossible because we don't have these unlimited resources. By definition, if we focus on initiative A, if we put our time and energy into initiative A, we're actually pulling time and energy away from initiative B. So we have these trade-offs that happen. And what a balanced scorecard lets you do is it lets you very deliberately and very purposefully define what those trade-offs are and what the relationship between those trade-offs. Because what we're really looking for is not perfection. What we're looking for is optimum performance. And optimum performance is really defined as the best possible results under the specific conditions that exist. So under the constraints that exist, what is the best we can do? And the balanced scorecard gives us a way of actually measuring that and recognizing that there are trade-offs to be had. So this is what a scorecard actually looks like. And I'm going to spend a little time orienting you to the different components in the scorecard. And then we'll go through each one of them and outline how you go about filling them in, how you use them, and how you communicate and how they interact with each other. So across the very top of the scorecard, you have the different quality dimensions. So we have the 6 quality dimensions here. And I like to think of these quality dimensions as forming a quality chain with 6 links. If any one of these links is broken, excuse me, you've actually broken your quality chain. After all, you can have the most effective treatment possible. If people can't access it, then you can't say you're delivering high quality care. So you need to be able to demonstrate that you're delivering quality in each one of these areas. Otherwise, you can't comfortably say you're delivering high quality care. So by having each one of these quality dimensions here, we can actually be sure to structure ourselves so that we're measuring performance in each one of these quality dimensions. So underneath each quality dimension, you will have a set of 1 or more key performance indicators. And we'll go a little later on, we'll go into how we go about selecting those or choosing those. But suffice it to say that you should have at a minimum 1 quality measure for each single quality dimension. Otherwise, like I said, if you have that link and you aren't measuring anything to determine whether or not you're performing well in that particular area, then you really don't know whether or not you're delivering quality. So it is possible to have more than 1 measure for a quality dimension. In fact, you'd have 2, 3, or 4 measures if you like, and that is totally okay. It's really up to you and your team to identify what areas you want to focus on in terms of investing your energy. There's a realistic point, though. There's a very pragmatic point that once you get to too many measures, your scorecard will get too big and too unwieldy and too difficult to manage. You actually won't know what to focus on first or how to actually react to changes in performance if you get too many measures. And that sweet spot generally falls somewhere around the 10 to 12 measures. Anything beyond 12, and it starts to get very difficult to know how to respond to changes in performance and how to actually focus your energy. So realistically, your scorecards are going to look to be about anywhere from about 6 to 12 measures. You definitely want no fewer than 6 because you want 1 for each dimension, and probably no more than 12. So underneath each quality dimension here, we have a performance measure. And what this performance measure really just defines is it communicates to your team what it is you're looking at. If we go all the way down to the bottom of the scorecard now, we've got this weighting row. And what this weighting row does is it lets us define what the relationships are between these dimensions. So this is where we get into the trade-offs. And the way we go about determining this weighting is a little bit more art than science because it's actually driven more by your environment and your needs in the system or in the facility that you're functioning in. Because if you're in an area, for instance, that has efficiency well in hand and you really have no efficiency concerns, then what you might want to do is downplay or underemphasize the efficiency aspect in favor of other areas. So if you're having some accessibility issues, you want to overemphasize access as a dimension. And what this lets you do is it lets you tailor the scorecard and recognize the trade-offs by defining what the relative importance of each one of these dimensions are. You want each dimension to contribute to your scorecard, but they do not need to contribute equally. The one rule that exists is the sum of all of your weightings should add up to 100. In fact, must add up to 100. If it doesn't add up to 100, you do not have a balanced scorecard. You have a scorecard that's out of balance. So all of these should add up to 100. Now, across the vertical here, we'll have 10 different performance levels, and each one of these levels will have a threshold at which you go from one level to another level. So if we look at the length of stay in this very first column here, you can see the level 3 is set at 8.1 days. In order to get to level 4, you'd have to be performing at or better than 7.4 days. So there's a threshold that you go from one level to another. And the way we actually calculate your overall score is a simple product. It's simple math where you take your performance level for each quality indicator, for each column of the scorecard. You take your current level of performance and you multiply it by your weighting, and then you add them all up. So in this case, if we look at the efficiency measure, this particular scorecard, we're performing at level 9. Because we're sitting at 4.27 days, which pushes over 4.4 days. So we're sitting at level 9. It's weighted at 20%. Therefore, you do level 9 times 20 gives you 180. And then you do that for each column and you sum them all up. And in this example here, we see our total score down at the bottom right is 775. That corresponds to a level 7. So this is where we have an environment where we've had performance improvements. We've had some ups, some downs, some dimensions haven't changed at all. But overall, we've seen an increase in performance from a level 3 up to a level 7. And by having the scorecard laid out in this way, what you can have is a situation where perhaps you progress in one area, regress in another area, and are stagnant in a third area, but the overall progress is positive. So you're actually moving forward. So you are actually improving your quality, even though you're not improving it everywhere all at once. And that goes back to the earlier discussion, the earlier point about having these trade-offs. We can't do all of it all at once, and the scorecard lets us progress in some areas while regressing in other areas, and yet still measuring and assessing quality. So those are the various aspects, the different components of the scorecard. And we're going to go through each one of these now to talk about how we go about setting them, how we get to choose our indicators, how we set a threshold, and how we actually respond to that. Because the scorecard itself is not the end goal. The scorecard is actually the beginning of the process. It's how you react to your scorecard and how you use your scorecard that is the really powerful part. So I'm just going to go into a couple principles of measurement. Before we start talking about specific measures, we're going to talk about measurement in general. And there's an old management adage that you manage what you measure. If you don't measure it, you're not really managing it. And there's going to be some observer bias that will happen. By coming together as a team and selecting a measure and putting it on your scorecard, what you will see is you will begin to improve in that area because people become more mindful of that particular item. And it reflects, it's actually a very powerful signal to your team saying this is important, we are going to measure it. So everyone will naturally, it's just human nature, will begin to pay more attention to it. Another point is this question about the need for common measures. And it's very, very typical when you're talking about reporting, especially any kind of accountability reporting, that you'll define one set of common measures with one set of definitions, and everyone will be assessed and measured against that one set of definitions. And while that's very important, we definitely want to be comparing apples to apples wherever possible. When it comes to quality improvement work, the need for common measures is actually not as powerful as it is in other areas. And the reason for that is what you measure is very, very specific to your local environment. It speaks to your process issues or your communication issues or what's happening in your needs. So your needs might be very different than someone else's needs. So the need to actually be measuring the same things at two different sites, for instance, is not nearly as important as it is linking what you're measuring back to your local environment and your local bottlenecks that you're trying to address. So don't get too hung up on having a single standardized definition that everyone agrees to and everyone's going to measure it exactly the same way. What I will say is don't reinvent wheels. So if other people have defined measures that will be adaptable or pretty good for your situation, by all means, beg, borrow, steal those measures, come together in agreement. There's no need for you to come out with your own exotic measure just because you want it to be yours. Less is more is a really, really big, very important aspect of the measurement because we want to spend our time working on quality. We don't want to be spending our time doing a lot of extraneous data collection or measurement or analysis. So keep your measures to very simplistic, as simplistic as you possibly can, to reduce the burden of capturing that data and analyzing and really understanding it. So really focus on a smaller number of more impactful measures rather than lots and lots of less impactful measures. And finally, I want to highlight stretch goals. Stretch goals are very important for a team because it actually elevates everyone's performance and everyone tries a little bit harder. And what a stretch goal is, very simply, is just a goal that is very, very hard to achieve. So if you were to look at your performance, let's say we were looking at our readmission rates and you were sitting currently at an 8% readmission rate, you could set yourself a very achievable target. Let's say we want to get down to 7% readmission rate, drop the readmission by 1%. That's an achievable goal. It's close to your current level of performance. An aggressive goal might be to cut that down to 5%. Whereas a stretch goal is saying, no, we're going to shoot for the stars. And we're going to get this down to 3%. So we're going to drop our readmission rate in less than half. And what that does is it communicates to your team that we are going to shoot for excellence. The flip side is the stretch goal should be achievable. Even though it's difficult, it should be challenging. It should not be impossible to achieve. So because as soon as it becomes out of the realm of possibility, people don't believe it and they don't pursue it. So stretch goals are important. They do drive performance, but make them realistic. So I'm going to compare and contrast a little bit about quality improvement and research. Because in healthcare, there's lots of research going on. I'm sure you're all exposed to different aspects of research. And quite simply, the culture of measurement when it comes to quality improvement and the rationale and objective of the measurement is quite different than it would be in a research environment. In a research environment, generally, you're trying to do one very large test to test whether process A is better than process B, or whether treatment X is better than treatment Y, or whether people respond more to 1 versus 2. So generally, you want to control as much of the environment and change as few variables as possible and run a high volume of people through it, and then you compare in a one snapshot analysis, is it better, is it more cost effective, is there a difference between these two groups? In quality improvement, it's very different. You want to do many small sequential tests rather than one big test. You want to actually do lots of little tests and do them over time and look at trends and look at changes over time rather than a big compare group A to group B type test. Research, by its definition, tries to eliminate bias as much as possible because we want objective, observable results. When it comes to quality improvement, bias is okay as long as the bias is consistent. So if you're looking at things like we're just going to do human observation of hand washing protocols as an example. So just monitoring for 1 hour a day at random and looking at that. There's obvious bias there because you're not monitoring every hour of every staff member's day, but that bias is okay because you're trying to follow the rule of generally correct, not specifically wrong. So a little bit of bias is okay. We're looking for good enough to inform without being perfect. We're not trying to publish these results. We're not trying to put them up in the world's body of knowledge and have other groups compare and validate. What we're trying to do is we're trying to improve performance. So we're trying to get a sense of what is our current level of performance, and are we trending up, or are we trending down, or are we trending flat? So those are just a couple different aspects of measurement that are quite different from a research environment. So if you're comfortable in a research environment, when you start working on quality improvement initiatives, it might actually be quite a culture shock for you because it is quite a different objective. So when you are selecting measures, we talked a little bit about having measures on our scorecard, but when you are selecting measures, there's a couple of rules of thumb to follow. The first is you want your measure to be very easy to measure. We don't need highly sophisticated IT systems to track this and have a regression analysis. Sticky notes on a monitor with checklists and you count the number of checks is totally okay and totally adequate. What we're trying to emphasize is really focus on the easy to understand and easy to capture types of measures because it will actually reduce the burden of collection. The measure itself should be simple to understand. You should not have to have a PhD to understand the relationship between what you're measuring and what you're trying to achieve. So things like number of patients who discharged or who cleared a discharge criteria, or number of times that a piece of paperwork was filled out, or number of handoffs, or minutes between process X and process Y. Those are all very simple to understand, simple to describe, measures totally suitable for this type of work. When you start looking at odds ratios or hazard ratios or any kind of ratios, really, it gets much harder to understand the relationship between what you're measuring and what you're trying to achieve. And furthermore, ratios are bad for another reason, because if you do have a change in your performance and you're looking at a ratio, so let's say we looked at the ratio of patients discharged to patients admitted today as a ratio of some kind of quality indicator. If you have a change, you don't know whether that change is the result of a change in the numerator or the denominator. So did you discharge more people or did you have more people admitted? So ratios themselves should be avoided unless you really have a really good reason for doing it. Most of the time you want whole numbers, you want discrete numbers. So you want numbers, percentages, counts, minutes, averages. You don't want to do a whole lot of ratios. Your measures should also be holistic. And what I mean by that is they should be as representative of the continuum of the flow that you're trying to measure as possible. Picking up a very, very specific measure that only captures a little bit of the flow of the system that you're measuring isn't really all that informative unless you've got a very specific bottleneck. So if you were to look at the number of drug reconciliations on a Tuesday by Nurse Smith on Unit 7, that's probably a really bad measure because it's not reflective of the whole system. So try and be as holistic as possible. Pick those big measures that are really going to be reflective of big parts of the journey as much as possible. You also want to focus on areas where you have an opportunity for improvement. So if you were to do the Safe Surgical Checklist compliance and you were sitting at 100% this quarter and 100% next quarter and a 99.9% in the quarter thereafter, there's no room for improvement there. That's not a good measure because there's nothing you can change. The whole purpose of this is not to measure for audit purposes. it's to improve your performance. So if there's no opportunity for improvement, it's time to move on to a different measure. So in other words, be smart when you pick your measures. Pick specific measurables, make sure they're easy to measure, they are measurable, they're attainable, they're realistic, and they're timely. You want data to be fed back as quickly as possible. Generally speaking, there are three types of measures, and you should be mindful of all three. The first category of measure is really what we call a process measure. This might also be called a leading measure, and the reason it's called a leading measure is because it changes in advance of the outcome, so it leads the outcome measurement. So this really measures what you do. Examples of this include hand washing protocols or the percent of patients who've had a med reconciliation done. It's really measuring your process and what you do. Outcome measures, on the other hand, or lagging measures, they're slow to change because this measures what you have achieved. So process measures measure what you do. Outcome measures measure what you achieve from that change in process. So these are things like infection rate, satisfaction scores, length of stay. And generally speaking, these lag the intervention. So if you make a change in your system or in your process, the outcome measures lag that change. So you might make a change on Monday, you might not see that impact on the outcome for days, weeks, or even possibly months later. And that's why they're called lagging measures. The third type of measure is a balancing measure, and this is really to make sure that you measure unintended consequences. So these are things like medication errors, readmission rates. You don't want to be reducing length of stay and discharging people early if they're coming back because they were discharged before they were ready to actually go home. So these are a balancing measure to make sure that you aren't having unintended consequences. Other examples might include things like lost work time for injuries, or stress leave, or possibly any really kind of error rate or an impact on another service. So you want to make sure you're not cannibalizing one service by focusing on another. So those types of balancing measures. So when you build up your scorecards, you want to sprinkle them with a little bit of all three. But overall, you want to emphasize wherever possible your process measures. And the reason you want to focus on process measures is because you want to measure what people are doing and giving them feedback on their actions. It takes time for those outcome measures to materialize. So you don't want to disincent or depress your team if they're making all these changes and we're not seeing changes in the outcome measures just because they haven't materialized. You want more timely feedback. So focusing on things that you actually do, you're more likely to see changes in that in the short term, whereas outcome measures take longer to measure. So really, the unintended consequences, you should definitely have at least one, if not two, of these unintended balancing measures, just to make sure that you're not having those downstream negative effects. So the scorecard process, if we take a step back to the scorecard, really the first step is to identify an improvement indicator under each quality dimension. We talked about that. We'll get to more specific examples in a moment. Then you want to set the weighting, so you want to determine the degree of relative importance of each different indicator, so that's where you set that weighting. Then you go out and you collect baseline data to populate your current level of performance, your as-is state. Now, how you go about doing this, again, is a little bit up to you. You want to do a method that makes sense for the measure that you're capturing, but it will, again, we follow the rule of generally correct, not specifically wrong. So a couple strategies for determining your baseline data population is to possibly do a chart review. You can go back for the last month or the last week or the last quarter, or depending on the volume of data that you need to capture. You could also do some prospective tools. So you could say for the next 3 shifts, we're going to monitor this. I don't want to go back and do chart reviews. I just want to measure this going forward. And we're going to, just for this week, we're going to put a little data capture in just to tell us how we're doing. Again, generally correct, not specifically wrong. You want to know more or less, what is your current level of performance there? Another strategy might be to do a random sampling. So rather than do a chart review over the last 3 days or 3 weeks, you might just randomly pick 10 charts. Let's just randomly pick those 10 charts, do a chart review, and then use that as a proxy for the current level of performance. All of those strategies are perfectly acceptable. Really, what you're trying to do is define to your team what your current level of performance is, to identify whether or not there's opportunity for improvement and whether or not the data will reflect the anecdotal reality. There is no more powerful truth than actually having some data to back up your belief. Now, step 4, this is the really important part, because this is the hard part. And I said earlier that the scorecard isn't the end, it's actually the beginning. Because once you've got the scorecard in place and you've populated your as is, now you need to respond to it. And this is where you identify, well, how are we going to measure it? What data collection strategies are we going to put in place? And then what are we going to do about it? How are we going to move our performance from a level 1 to a level 10? And that's really the quality improvement methodology. And this is where we tap into strategies like the PDSA, the Plan, Do, Study, Act methodology, or Lean Six Sigma, or any other quality improvement methodology. But essentially, they're all based on the same thing: is you develop a plan, you put that plan into action, you study it, and then you respond to that, and you do lots of these sequential little changes to see if we're moving in the right direction. So we talked about just reflecting back on our earlier discussion about the scorecards and setting targets. So as I mentioned, you go out, you do your baseline performance measure, however you want to do that, whether that's a retrospective chart review, whether that's a prospective short-term data capture, whether that's a sticky note on a monitor and you have someone literally take notes for one shift or one day or 1 week or 1 quarter, or however you want to actually set your performance level. That goes on to your scorecard now as your level 3 performance. You always start at level 3 as your baseline performance. Then you define what is ideal. And ideal performance may be determined by a provincial benchmark. There might actually be a clinical benchmark in this area. It might be you sitting back saying, okay, realistically, what could we achieve in a year? If we're sitting at a 40% failure rate, what could we realistically expect to achieve in the next 12 months? And then you set that stretch goal, but ultimately you want to establish an ideal. If you do have clinical benchmarks, if you've got a body that said, this is the ideal infection rate, by all means adopt that as your ideal performance. If you don't have those benchmarks, lots of areas we don't have benchmarks defined, sit down as a team and say, guys, what are we actually going to achieve here? And set a stretch goal for your ideal performance. Then we go about establishing what the thresholds are to go from level 3 up to level 10. We reflect when you're setting these thresholds. It's important to remember that the better you get, the further up towards closer to the ideal you get, the more difficult it becomes to improve. So if you're sitting at a level 40, going from a level 40 to a level 50, like in this example, going from level 3 to level 4, is a 10-point gap. That's actually easier than the next stage, which is going from a level 50 to a level 55. That's a 5-point gap. So when you set your thresholds for each one of these levels, it's probably worthwhile to set the gap between thresholds to be bigger in the lower levels, because it's easier to improve at those lower levels of performance. And then as you go up and get closer to ideal, making smaller and smaller increments is certainly possible. It is certainly desirable, because it's getting harder and harder and harder to improve. So you want those improvement thresholds to be smaller. That's not always possible. And in fact, if let's say there's only a 10-point difference between your current level of performance and your ideal level of performance, you might just have to do a linear. So it's just divide by 10. We're sitting at 40, we're trying to get to 50, divide it by 10, and then each threshold becomes 1 or 2 or whatever that score means. That's okay too. Again, this is the rule of the day is generally correct, not specifically wrong. There's a little bit of art in this and a little bit of science. So it really is determined by what measure you're measuring, and also how far away from the ideal are you. The further away you are, the more you want to spread larger improvements lower down and smaller improvements up at the top levels. The closer you get to ideal, the less practical that becomes, and you might just have to go to a linear unit of measure. So the quality improvement methodology, once you've got the scorecard in place, this is where it really feeds into a larger quality system. And the scorecards are just one piece of this, but I just want to reflect that there's more to it than just putting a scorecard, measuring it, and putting it up on a wall. This is now, you need to actually foster that quality culture within your team. So it's really a different way of thinking. It's really about focusing on the PDSA cycle or the IHI improvement methodology to say, okay, let's take these tools, put them into action. So we get together with our teams, we review our results, we discuss our results openly, and then we troubleshoot and we brainstorm and we come up with ideas, and then we'll test those ideas on a small scale. And that's the quality feedback loop. The scorecard itself really becomes your tool for measuring whether or not those ideas that you've brainstormed with your team are having a positive, negative, or immaterial effect on your performance. So how do we go about developing one of these changes? How do we actually know what to do when we see our measurement and we see we've got an opportunity for improvement and we want to go ahead and make a change? How do we know what change to make? So this is where we get into some brainstorming ideas. And it's really, you need to engage with your local team because your team understands the system they work in. They're going to know the bottlenecks that exist. They're going to know the process barriers. They're going to know a lot of the changes that can lead to a positive impact on quality. A little bit of critical thinking is helpful. Use technology wherever it's possible. If you've got IT systems that you can leverage and do some of your capture and do some of your reporting for, absolutely use that technology. And get creative. Really start thinking creatively about your environment. And sometimes that means you just have to kind of step out of your environment, apply some creative thinking, and come up with these interesting ideas. We'll talk a little bit more about change concepts in a second, but the change concepts really let you focus on a couple areas that are important, that have a high probability of leading to success. And finally, copy from your colleagues. Plagiarism is the ultimate compliment. Don't feel the need that you have to come up with a creative, innovative, never thought of before solution, because your colleagues across the province and other sites and other units, they're struggling with the same issues you are. Some of them have fixed them or addressed them. So wherever you see success, steal blatantly. Don't be ashamed to steal from your colleagues. So change concepts are really just a way of looking at your system and trying to think of, well, what do I focus on? And these are developed from all kinds of different systems. So Lean Six Sigma, we've got operations management methodologies. It's just basically what these all boil down to is look for reducing variation and reducing non-value added steps. So reduce variability in your equipment, reduce variability in your process, reduce the different steps involved necessary to move through your process, use your resources as much as you can. So when you've got a scarce resource, really exploit it. Don't let it sit idle. So if that's a person or if that's a piece of equipment, make sure you're really exploiting that resource, and I mean exploiting in a good sense, to the maximum possibility. To the maximum possible. And here's just a couple examples. So when we look at reducing the number of components, look at, for instance, standardizing your OR instrumentation, optimizing your inventory, centralizing your ordering. Giving access to information is actually a great way to drive change. Many of the challenges that we see in healthcare, many of them stem from really about communication issues or breakdowns in communication, whether that's in patient handoffs or in process handoffs. So finding ways to get information as patients move through the system or as providers move through the system, getting that information from point A to point B in very creative, simplistic ways is very, very effective. When we look at many of the changes that have actually proven very effective, they have been very straightforward types of changes. We're not talking about redesigning IT systems and changing our order entry or our clinical decision support. We're talking about putting whiteboards in place so that we can actually communicate between team members, standardization of messaging or signaling so that when a patient has cleared process A, we have some kind of signal to the team that they can continue on and look at maybe the next stage of that processing. So focusing on variation is another real area, very, very rich area to focus on. So variation generally means cost and quality. So when you have variation, whether that's variation in process or variation in flow, that almost always culminates in a higher cost or a lower quality. So focusing on variation is very, very important. Error proofing is another example. Realistically, if you rely on people's diligence, on people's mindfulness to do the right job, you can comfortably get to about a 90% error proof rate. Anything above 90%, so if you want a 99% reliability, you cannot rely on diligence to do that. The human mind is not capable of being that diligent for long periods of time. So that's where you have to put into place error proofing. And these error proofings can be very straightforward. They don't have to be high-tech error proof. It can be very low-tech. The safe surgical checklist, the OR timeout, these are examples of error proofing steps, very low-tech, very effective. I know one site, they actually put in place a little cardboard cover that goes over their scalpel, and you don't take that cardboard cover off the scalpel until you've completed the OR checklist. That's an example of error proofing. Very low tech, very, very effective. So if you want to get to a point where you're not looking at a 10% failure rate, if you want to get that to a 5% failure rate or a 1% failure rate, then you need to put into place these error proofing steps. And it goes from, human diligence to reminders and alerts will probably get you from a 90% reliability to about a 95% reliability. If you want to then get to a 99, then you get into things like decision support tools and guided decision and wizards and things that are driving the right behavior. If you want to get to a 99.9%, then you need really focused quality systems that are guiding decision making and making it difficult and interrupting your flow if you're making a wrong decision. That's generally in healthcare. We're heavily reliant on diligence. We're only now starting to scratch the surface on decision support and guided and alerts. So getting to a 99.9% reliability rate is very challenging, but starting with very simple error proofing is actually a very effective strategy. So one way of looking at a problem, let's say we do have a problem. This is this tool I've got on screen. This is an example. It's called the fishbone diagram. And it's just a very convenient way of breaking down big problems into smaller, more manageable problems. And what we have here are the 6 M's. So this is saying, well, how do I take a problem and break it down? Well, one way to do that is to look at these different 6 M's. So look at your machines, your manpower issues, your measurement issues, your material issues, your methods issues, and then Mother Nature. What's going on that's beyond my control? And all you do is you take a problem, you put your particular issue in the little box, and then you brainstorm with your team. Okay, what are each of these different aspects? Which ones of these are contributing to the issue? So if we look for an example as length of stay beyond 7 days, well, what are my machine-related income issues? What are my manpower-related issues? What are my measurement systems? What data don't I have? What information isn't flowing? What material issues do I have? What are my methods? What are my processes that are contributing to that issue? And then what's out there in the environment that I don't control but I need to be aware of? And when we look at it in these groupings, what you can do is you can start identifying opportunities for improvement. So manpower can generally be addressed by scheduling or resourcing. Equipment can be, or machines can be addressed through, changes in capital sharing or procurement or time sharing of equipment or whatever that might be. But this lets you take a very complex problem like an extended length of stay and break it down into more actionable items. So I can look at any one of these bullet points and say, okay, I know this is contributing to my issue. How do I now address it? And you can focus down on smaller, more manageable issues. Another tool that can be helpful is called a driver diagram. And this driver diagram, you read it from right to left. So you brainstorm with your team on ideas for process changes. So let's say we're looking at a particular process. You literally throw this out to the team, and they start doing some brainstorming. Well, what can we change? And then you group those ideas as themes start to emerge. You group them into different themes, into different secondary drivers, and then you move to one category to the left. You look at the secondary drivers. So as your ideas kind of cluster, then that defines a new driver, and then those start to cluster around. Okay. Those become your primary drivers. And an example here is, getting a patient discharged to plan. Your ultimate goal is at the far left. But if you're sitting there with your team, you might be saying, okay, what can we do to make sure patients get discharged to plan? And they might throw some ideas out. Let's, put the communicate the discharge date on the whiteboard. Let's make sure our messaging of our team is all saying, 7 days. You're going home in 7 days. Well, those are all communication coordination issues. Similarly, other themes will emerge, and you can talk about how, getting functional and readiness assessment things in place, getting TheraBands in the room really contribute to, a patient being functionally ready to go home. Then those drive into, okay, making sure the patient's ready to go home, and then making sure the patient's able to go home. Those become your primary drivers. And this one, a driver diagram really is more of a grassroots tool. So you start with your ideas, and then you kind of cluster your ideas around themes. But it gets to the point of taking complex problems and making them more simple and more actionable. That's when we apply the PDSA, the Plan, Do, Study, Act methodology. This is a very common quality improvement methodology. And the reason it's very common is because it's very effective. And whether you're using Lean Six Sigma is another common tool in manufacturing and in healthcare. Lean Six Sigma has its own model of the PDSA. It's called the DMAIC, DMAIC. It just adds more steps. But ultimately, it boils down to the same thing. Regardless of what quality improvement initiative or methodology that you subscribe to, they all essentially boil down to the same key components. You make a plan to make a change. You do the change on a small scale, you study the impact of that change, and then you respond to it. So before you make any change, you should go through your PDSA, and this doesn't have to be a formal written report. You can do this on the back of a napkin. But at the outset, you should identify, what are we trying to accomplish? How will we know whether we've made an improvement? And then what changes can we make? Then you put your PDSA, and before you actually make that change, you should communicate as a team and identify, okay, what change are we going to make? How are we going to make it? What are we going to measure? And what do we expect to see? And how do we respond then to if we see that result or if we don't see that result? And if you do that before you make the change, it makes it very easy then. You're spending your energy actually making the change and assessing it, rather than making this change, putting a data capture in place, and then sitting back and saying, well, now what do we do? Was it good, bad? I don't know. You do all that effort before you make the change, and it makes it a lot easier for you to determine whether or not your change has been successful. And I'll give you an example, walk through a case study as an example here. Let's take a look at hip fracture patients. The provincial standard is that 90% of patients should be getting to the operating room within 48 hours. You've got your measurement in place, and you're seeing, well, your patients, only 70% are getting there within 48 hours. So you've sat down with your team, you've applied some critical thinking, you've looked at your system and say, okay, let's identify my patient flows. Where are patients moving? How are they going through the system? Do we have any bottlenecks? And then let's do a little bit of investigation of root causes. We'll apply, the fishbone diagram. We'll break it down into what are all the different, machine measurement, manpower type issues. And you look at that, and then you build up your driver diagram, and you have this very simple set of drivers that either the patient is ready to go to the OR or the patient's able to go to the OR. Those are your primary drivers, and you've got some ideas on your team. But what you notice is that in this particular case, your team suggests, you know what, we really need to look at anticoagulation reversal. It's causing delays. Patients can't get to the OR because their anticoagulation is not reversed. So this is where we say, okay, let's apply the PDSA cycle. What are we trying to do? We're trying to reduce delays to the OR. Well, how will we know that we've improved that? We'll see a decrease, an increase in the percentage of patients that get to the OR within 48 hours. And what changes can we make? We're going to focus on reducing delays related to anticoagulation. So now we put in our PDSA. In this case, we're actually doing a very, very aggressive plan, which is we're going to alter the order sets so that we begin reversing the anticoagulation in the emergency room. This is a big change. Most PDSA cycles are going to be much smaller than this. You're going to be focusing on, communication, or you're going to be focusing on a particular protocol, or maybe, a type of drug therapy, or a handoff, or a staffing realignment. But in this case, we're going to say let's change an order set. The testing, the doing of that, we're going to do that in one site. We're not going to do this across the province, across the city, at multiple sites. We're going to do this at one site, or maybe we're going to do it for a day and see whether or not that has had an impact. Then we're going to study it. So we're going to sit there and we're going to put in place a feedback loop. So what we're going to do is anytime a patient's delayed, we're going to look at how many delays were related to anticoagulation. Now we're going to put a little check sheet in place, and we're just going to monitor that for at the one site for that one day that we've made that change. And then we're going to act, and we're going to say, okay, let's monitor it, let's look at the feedback, and then we'll decide if we do see a decrease in the delays due to anticoagulation, well, then let's deploy it to all sites. If we don't see a decrease in delays, we'll abandon the idea. The abandonment of quality ideas is not failure. In fact, it's success. If you try something and it doesn't work and you stop trying it, that is success, because you've actually averted all kinds of effort related to an ineffective change. So this is why we apply the PDSA cycle, to make sure we're not spreading ineffective or inefficient changes. And if you test something and your staff come back and say, yeah, we could do it, but it's going to kill us because of the data collection involved or because of the extra steps or manpower, then that's not going to be sustainable. That's not going to be a change. So abandoning a change because it doesn't work is a good thing. Then you can move on and more rapidly start brainstorming other changes. So that brings us to, we've gone through the scorecard and how we set up a scorecard, how we actually set up our baseline measures, how we define different measures. We'll use the SMART principles. We'll steal blatantly from our colleagues. We'll set our performance thresholds. We'll put this all together, and we'll put it on our scorecard, and then we'll respond with the quality improvement methodology, the PDSA cycles. We'll have our quality teams do some brainstorming. We'll look at root causes with driver diagrams and fishbone diagrams and break it all down and come up with all kinds of ideas. So now you've got your scorecard. Well, how do we communicate with the scorecard? And an important thing to realize that the scorecard is yours. It's yours and your team's. So that means you can change the measures on your scorecard within limits. Generally speaking, most scorecards have one or two measures that are deemed so important that everyone's going to measure them. But the other measures are really driven by your environment. So you need to own them because they need to reflect your challenges and issues. And your issues don't exist at other sites. They exist at your site. So what's important to you and your team is reflecting that the measurement that's in place in the scorecard reflects your current processes. So you control the measures, you control the action plans, and that means that you periodically reset the scorecard. This isn't a report card at school where everyone wants an A. If you're sitting at a level 10 performance for 2 quarters, it's time for you to reset. And when you reset, you either set a more aggressive goal, so you elevate your level 10, you reset back to level 3, and you say, no, ideal used to be at 5 days, now we're setting it to 3 days. So you increase the stretch goal to get a higher level, or you completely change the measure and say, you know what, we fixed this. It's time for us to move on and pick another measure. If you're sitting at 99, 100% compliance with whatever, quarter after quarter, it's time for you to drop it off your scorecard and focus on something new. So every now and again, you're going to go from a level 7, level 8 on your scorecard back to a level 3. That is not a failure. That is not a regression. That is actually the tool succeeding because you're moving forward. Similarly, if you're sitting there and you're at a level 3 and you've got a measure and you're making all these changes and nothing's effective, nothing is actually materializing and having any kind of impact in that area, similarly, you need to reset. You need to focus on something else. So if you're not moving forward, if you're stagnant, pick a different measure or pick a new action plan, because regression is not failure, but stagnation is not failure either. It just means, you know what, those changes aren't effective, so let's make different changes. Let's focus on a different area of the score of our performance, and that is okay. This is a tool for you to use to feed back to your team to identify opportunities for improvement. So if you're not improving, it's time to move on. So if you're stable, you're just sitting at level 5 and it hasn't moved in 3 quarters, that is a trigger for you to reconsider your action plans or reconsider your measure altogether. So success to date, scorecards have been very, very effective. They're great feedback communication loops. I know it's inevitable that there are executives and managers out there who are looking at the scorecards and using them as an assessment of quality. And then they see the levels of performance go from a level 7 back down to a level 3, and then all of a sudden people get concerned. This is where it's important for you to communicate using the scorecard to say, no, we're just being more aggressive now. We're moving the benchmarks. The goalposts are that much further away, so we're recalibrating. So the scorecard gives you a mechanism to do that if everyone understands exactly what they're looking at. It's very different than a top-down audit tool where you set one measure and you measure it, and if you move away from ideal performance, then all of a sudden all these red flags go off. That's not how these scorecards actually work. This is just an infographic that really reflects much of the work that's been done here in hip and knee arthroplasty in this particular example, but it's also being used in hip fracture with great effect. And we've had very good success with it, so I'm very keen to see this methodology spread further. If you do have any questions, by all means, you can email me at the Institute. We will be sending out this package with the slides and contact information. And I do want to thank you all for joining me today. And I wish you the best of luck in all of your future quality improvement initiatives. Thank you very much.